Good evening, everybody. I am Dr. Shipra Agarwal from the Department of Pathology. So, welcome to everybody for today's clinical pathology discussion. We have over here with us Professor Taru Garg. She is the Director Professor in Department of Dermatology at Lady Hardinge Medical College. Ma'am, we are happy to have you over here with us. She, after doing her post-graduation and senior residency from AIIMS, joined Lady Hardinge Medical College in 2006 as Assistant Professor and was subsequently promoted to Director Professor in 2019. She has 79 publications in various national and international journals and has written 10 book chapters in various dermatology textbooks. And she has also received the much coveted Sardari Lal Memorial Award for the best paper published in Indian Journal of Sexually Transmitted Diseases and AIDS. Her special areas of interest include sexually transmitted infections, leprosy, and pediatric dermatology. Ma'am, we welcome you over here to present the case. Thank you.
Good afternoon, everyone. So, thanks for the introduction, Dr. Shipra. I just want to say that I was discussing with Dr. Khaitan also that I was presenting the cases as resident at one point of time on this platform, and now I'm presenting it as a faculty. So it's a moment of pleasure and pride for me. Thank you so much. Thank you for inviting me. So, without wasting much time, I'll start with the clinical details of the patient which were provided to me. And along with this, I'll discuss my differential diagnosis. Uh, 67 years old male presented with multiple vesicobulous lesions and crusted plaques over the face. So started from face and progressed to involve the trunk and the extremities in next 6 to 8 weeks time. He also had oral and conjunctival mucosal involvement along with the erosions, and he had mild difficulty in eating spicy food, and other mucosal surfaces were unaffected. So with this history, it appears that there was not much severe mucosal involvement. There was a history of pain abdomen off and on for 1 month and progressive loss of appetite for past 1 month. He was a known diabetic and hypertensive for last 7 years and was receiving metformin, telmisartan, and amlodipine. General physical examination was normal except a raised pulse rate, which was 98 per minute. Cutaneous examination revealed generalized involvement in the form of vesicobulous lesions all over the body. There were few target lesions which were confined to the distal extremities, face, and scalp. He also had tense bullae over the face, along with few crusted erosions. The lesions were mainly flaccid over the trunk. The contents were clear to turbid fluid, and there was no history of any hemorrhagic fluid-filled lesions. In addition, he had multiple punched out ulcers which were present over the groin, scrotum, and penile shaft, and the total body surface involvement was around 25 to 30%. Nikolsky's sign was negative, both direct as well as indirect. So this is a clinical picture where we can see these vesicobulous lesions, and what we can see, most of the lesions, they are pus filled. You hardly see any lesion which has a clear fluid in the within this bulla, and there is prominent surrounding erythema, some erythematous plaques also, and some lesions are showing central this hemorrhagic crusting, and few targetoid lesions also one can make out. Another picture which shows lesions on the forearm, where again you can see these bullous lesions with the content is again turbid fluid, looking more like pustular lesion. And in addition, he had this targetoid lesion. So it appears that lesions are present over the erythematous plaques, or maybe these are bulla with surrounding prominent erythema. Picture showing the similar lesions. Lesion on the hand, which is targetoid in nature. You can see lesions on the face, where on the forehead there is a clear fluid-filled bulla. Then there are ulcers with hemorrhagic crusting. Again, on the cheek, you can see similar lesion with hemorrhagic crusting. And in addition, these few lesions, they appear little nodular and infiltrated. Clinically, I'm not sure about the consistency and everything, but clinically it looks like that. Systemic examination was normal. So if I go by the initial picture which was provided to me, the clinical details, I'll think in lines of paraneoplastic pemphigus because of presence of multiple vesicobulous lesions along with targetoid lesions, polymorphic lesions, involvement starting from the face and gradually involving the trunk and then extremities. But I would like to keep certain differentials like any other autoimmune bullous disorders like bullous pemphigoid. As there was some ulceration and crusting in some of the lesions, I would also keep a possibility of bullous pyoderma gangrenosum as well as bullous Sweet syndrome. And just to rule out erythema multiforme in view of these targetoid lesions and mucosal involvement. So these would be my provisional diagnosis with this much of a clinical details and examination. So skin biopsy was sent by the treating department for histopathology, and I hope for the immunofluorescence as well. The patient was admitted after that, and the lesions evolved into the large ulcerated plaques with hemorrhagic crusting in the hospital, especially over the trunk and the extremities, and another set of biopsy was repeated from these lesions. So if you look at these lesions carefully, you can see it is not only vesicobullous disorder, something else is happening on the face. As you can see, these nodular lesions, shiny lesions, and these ulcerated plaques which are also little raised and seems to be infiltrated. So would like to add more after this in the differentials, that is bullous Sweet syndrome, rare maybe bullous cutaneous lymphoma or bullous leukemia cutis, which have rarely been described, or maybe bullous pemphigoid with cutaneous lymphoma. These would be the additional differentials. Patient was treated with prednisolone and IVIG without much response. So that is another pointer which could favor the later diagnosis. So the condition deteriorated while he was he was admitted. He developed tachypnea on day 15. He had to be intubated on day 22. He developed sepsis, started on inotropes. The blood culture revealed E. coli growth, and he also developed septic shock and expired on day 25. So these are the investigations which are available. So on day 1, you can see that hemoglobin was normal, which became reduced to 8.8 on day 24. There was leukocytosis, which goes either in favor of maybe the patient had septicemia or secondary infection, or it also favors the diagnosis of neutrophilic dermatosis. In the differential counts, you can see that there was neutrophilic leukocytosis. Platelet counts were normal. Peripheral smear did not show any atypical cells. He was a known diabetic, so this is the sugar level. Sodium was low. He had hyponatremia, but no hyperkalemia. I don't see any hyperkalemia in this report. Liver functions were mildly deranged, SGOT and SGPT levels. He had hypoalbuminemia. So albumin was 2.7 at the time of presentation and reduced to 1.1. Procalcitonin levels were raised. You see on day 8 and day 14, which suggests he had maybe septicemia. LDH was raised, which can be because of various reasons. It could be because of infection, it could be because of inflammatory diseases, or it could be because of malignancies. C-reactive protein was raised, which again suggests it could be because of infective pathology or inflammatory pathology. Viral markers were negative. Urine routine microscopy showed sugar, trace proteins, and ketones. Stools routine microscopy showed occult blood positivity, which could be because of associated malignancy or maybe some other GI pathology. Zank smear showed acantholytic cells, which suggest an intraepidermal pathology. So may go in favor of diagnosis of paraneoplastic pemphigus, but there can be secondary acantholysis also, which can be seen in other conditions, as most of the lesions had turbid content. Then CECT chest and abdomen, it was a normal study, and blood culture report, which was available on day 27, showed growth of E. coli, which was sensitive to various antibiotics. Bone marrow was not done, either aspiration or this biopsy. I'm not sure about that because the report has not been provided. So with this background, let us see what could be the causes of vesicobullous lesions in elderly or with this kind of presentation. So it could be generalized with systemic illness and without systemic illness. So if we take with systemic illness, it could be severe form of drug reaction, it could be severe form of viral infections, or it could be autoimmune disorder like bullous SLE, or can be associated with internal malignancy like paraneoplastic pemphigus, or rarely it could be cutaneous lymphomas and leukemia cutis. Generalized without systemic illness can be various autoimmune disorders. Not relevant. Other causes could be bullous pyoderma gangrenosum, again rare, and these are the other causes. So let us have a look on the differentials which I kept. First is the paraneoplastic pemphigus. So it mainly involves the upper body, palmoplantar involvement. The lesions are polymorphous and targetoid lesions are present, but this is characterized by severe mucosal involvement. It may involve multiple mucosal surfaces, and these are refractory to treatment, very painful, very severe. And it shows poor response to systemic steroids. So these are the features which are present in our patient. Bullous pemphigoid, it shows tense blisters, intense pruritus, age goes in favor of this. It can have a presentation like ecthyma gangrenosum, which has been described. However, mucosal involvement is rare, and in fact, you can see intact blisters in this. So that is not in favor of this diagnosis. It can be associated with internal malignancies, although this is not proven. It shows good response to treatment. Pemphigus vulgaris, it's not really a differential diagnosis, so I'm not discussing this. Eczema multiforme major, again, can have targetoid lesions, mainly confined to extremities, but this has more acute onset, and there is extensive mucosal surface involvement and association with drugs and the viral, which was not the case in our patient. Then bullous pyoderma gangrenosum can present with hemorrhagic bullae on the arms, upper limbs, and it usually heals with the scarring. So with these pictures, one cannot make out any scarring or anything in this patient. Mucosa are rarely involved. It can have an association with hematological malignancies, and it shows good response to steroids and dapsone if it is not malignancy associated. Then bullous sweet syndrome. Bullous variant is an aggressive form, usually seen in association with the malignancy, and can present as bullous hemorrhagic rash. Then another one is leukemia cutis, which may be a presenting sign of malignancy, maybe either preceding, following, or concurrently with the diagnosis of this hematological malignancy. Cutaneous T-cell lymphoma, especially the aggressive variety, aggressive or large anaplastic type, they may show rapidly evolving, extensively ulcerated annular plaques associated with poor prognosis. And these are defined clinically by the rapid onset of erosive or ulcerated plaques and sometimes ulcerated nodules without preceding history of any patch or plaque. Mucosal involvement is not really seen in these cases, but it has been described. Gram-negative septicemia itself can also present as bullous hemorrhagic lesions over the extremities along with the purpuric lesions. So let us see these conditions along with the clinical features which were present in our patient. So age goes in favor of each of these diagnoses for all of these. Even for these, age is not a problem. Then, Then pain abdomen again can be seen because of presence of internal malignancy or can be non-specific. Loss of appetite would be present if there is an associated internal malignancy or any malignancy. Vitals not significant. Vesicobulous lesion, flaccid and tense. Basically, we use this thing just to differentiate between an intraepidermal and subepidermal pathology, and there can be overlap of this also. Contents again, clear or hemorrhagic, we tend to differentiate between intraepidermal and the subepidermal pathology, which again, there can be overlap. For cutaneous cell lymphoma, age, as I already described, then loss of appetite can be present in these leukemia, lymphoma, or bullous-Sweet syndrome. Vesicobulous lesions have rarely been described in these conditions. Targetoid lesions can be seen in paraneoplastic pemphigus, bullous pemphigoid also, erythema multiforme also. Mucosal involvement can be seen, and it is very severe in cases of paraneoplastic pemphigus, as I described earlier, and can be severe in erythema multiforme. Ulcerated hemorrhagic lesions are seen in bullous pyoderma gangrenosum. Punched out ulcers are seen in bullous pyoderma gangrenosum. These can be seen. Out of these conditions, targetoid lesions are not seen. Ulcerated hemorrhagic plaques are seen in cutaneous lymphomas, leukemia cutis, or bullous-Sweet syndrome. Punched out ulcers again can be seen in these three conditions. Mucosal involvement may or may not be seen in these conditions. Then raised TLC would be seen in bullous pyoderma gangrenosum, or in any of these conditions if there is associated secondary infection. Occult blood would be seen in these two conditions because of internal association. In Zank smear, acantholytic cells were seen, which goes in favor of these two possibilities. PET scan images which were provided shows uptake by the skin lesions. So PET scan positivity can be because of cutaneous malignancies, but sometimes you see positivity even in inflammatory conditions or in infective conditions also. This is really not the criteria to differentiate between these two, although if maybe a person from a nuclear medicine would be better able to answer this question. Or a poor response to steroid would be seen in paraneoplastic pemphigus. Cutaneous lymphoma, raised TLC again can be in favor of these conditions. Then CCT abdomen may show findings if there is internal involvement in these conditions. PET scan positivity may be positive in cutaneous lymphoma, leukemia cutis, and plus minus in other two conditions. Poor response to steroid would be seen in cutaneous malignancies. So I have just taken out few images from the literature which have described these rare cases of bullous leukemia cutis, where you can see these nodules and central hemorrhagic crusting and a bullous lesion, or bullous MF, where you can see these bullae and a ulcerating plaque, or paraneoplastic pemphigus. All of us are aware it can present with polymorphic lesions. And bullous-Sweet syndrome, where again you can have nodules with hemorrhagic crusting and vesicobullous lesions rarely. Or bullous pyoderma gangrenosum, where a person can have these bullous lesions with significant erythema surrounding this, and these lesions have a tendency to ulcerate. So if you go by history of vesicobullous lesions with clear and turbid fluid filled, polymorphic lesions, targetoid lesions, mucosal involvement, although it is not very severe, presence of acantholytic cells, and poor response to treatment, one would think of paraneoplastic pemphigus. However, when you see these erythematous plaques with bullous lesions, which appears to be on top of these plaques and having turbid contents along with raised TLC, LDH, you may think of neutrophilic dermatosis like Sweet syndrome or bullous PG with underlying myeloproliferative disorder. And when you see this picture, which you can see on the face, bullous lesions on the forehead, ulcerative plaque with hemorrhagic crusting, few lesions which appear to be nodular and infiltrated, along with positive uptake by the skin lesions on PET scan. That may suggest these possibilities, which are very rare conditions. So that is why I've kept it in the end. So, but these could be the possibilities with or without associated conditions like bullous-Sweet syndrome, bullous pyoderma gangrenosum, or paraneoplastic pemphigus, along with septicemia. So what to do? Histopathology done from various lesions is definitely going to help us for making a diagnosis. PET scan findings may or may not be helpful. So a colleague from nuclear medicine may be able to help us. Bone marrow aspiration and biopsy may also help because sometimes atypical cells are not seen in the peripheral smear, but still you can get some findings in the bone marrow. So I leave the discussion over here for the others. And thank you so much. So if there are any questions, we'll be happy to answer.
For the beautiful discussion we had over here. I will like to now invite the audience for any possible differential diagnosis. Any other possible differential diagnosis from the audience?
Lichenoids, especially on the trunk and the extremities. Facial lesions, of course, were very different.
Various morphologies were present. It was not only lichenoid, there were plaques, there were like targetoid lesions, there were nodules, there were ulcerating lesions with hemorrhagic crusting. So that is the reason that that possibility was not considered.
Not seen the pictures of the mucosal involvement, but do we have information on how extensive the oral and the conjunctival involvement was there? Was there extensive oral involvement? Was there desquamative gingivitis, etc.?
But actually, the clinical details which were given to me, there was mild difficulty in eating the spicy food. So that suggests that probably it's not a severe mucosal involvement. And if you see the picture on the face, the conjunctival involvement, that was also not very severe. It was only single this thing. And there was no history of dysphagia or anything which was provided. So it seems to be a kind of involvement which would not be seen in paraneoplastic pemphigus.
Sir, it was my patient, and he had a single ulcerated plaque on the palate, and the conjunctival involvement occurred later in the course, and there was no gingivitis, desquamation in the gingiva, or extensive oral erosions. So it was a very mild oral involvement, and no other mucosae were affected for a large part of the disease course.
Was it a well-defined lesion in the oral cavity?
There was a single erosion about 1.5 to 2 centimeter in size. It did not have any induration at its base or at the edges. So for us, initially when we saw the patient, because there were flaccid vesicobullous lesions, there was oral involvement, the Zank smear showed acantholytic cells. So we were, and there were polymorphic lesions like erythema multiforme and even erythema multiforme-like lesions and somewhat some lichenoid lesions.
So hold the final diagnosis till
Yeah.
the end, but
So
she
I'm
can
not-
tell what they thought at the
Yeah,
time.
so as the treating clinician, my differentials included paraneoplastic pemphigus, pemphigus vulgaris, and erythema multiforme. So these were the differentials with which we sent the first biopsy.
Any more comments? Yeah.
Thank you, ma'am, for nice clinical discussion. You told only the broad term cutaneous, aggressive cutaneous lymphoma, only MF. Are you thinking of any forms of cutaneous lymphoma? Or would you like to narrow down apart from mycosis, fungoidosis?
If you see, have only been described for mycosis fungoides. For aggressive form, I checked, it has not been described. For a large anaplastic type of this, also it has not been described, but why not? When you can get it in MF, you can get it in other lymphomas also. It's just that these cases have not been reported probably.
Anaplastic large cell lymphoma to be extensive lesions. Usually they present as a solitary nodule. As per the pathology,
But
it is usually presented as solitary ulcerated nodules, but this seems to be a extensive.
yeah, but both the kind of presentations have been described actually. Can have both the kinds of presentation.
Dr. Raja, will you like to add something?
This is very atypical of what Somaranjan was telling. Any lymphoma presenting like that with so much of bullous lesions and vesicles with first like uh, material inside that. This is very atypical of a cutaneous T-cell lymphoma at this stage.
Actually, to explain that, maybe I have, that's why I said that maybe it's a bullous-Sweet syndrome along with cutaneous malignancy that could explain extensive bullous lesions. That is one thing. But if you see the lesions, carefully, the lesions were infiltrated and nodules, especially on the face, which I was, pointing out. So that kind of lesions you would not see in other conditions, in the psychobullous conditions. It's probably an association of these cutaneous malignancies along with maybe bullous-Sweet syndrome or maybe bullous pyoderma gangrenosum. I'm not sure, but that could be one of the possibilities. And that is the biopsies required from both the kinds of lesions along with DIF. Even bullous pemphigoid has been described in association with lymphomas. That is the other thing as a paraneoplastic phenomena.
Dr. Rakesh from nuclear medicine, will you like to say something?
Yeah, the patient was referred for PET scan, and we were supposed to look for any other malignancy for the paraneoplastic, and we could see uptake on the cutaneous lesions only. So there was no other lesions within the body showing any abnormal FDG uptake where we can suspect primary and for the guidance of the biopsy. Regarding primary cutaneous lymphoma, I have one paper, and we have not seen such lesions in the primary cutaneous lymphoma. They are more of like known, not pus or not so much indurations. Yes, secondary cutaneous lymphoma can be there, but there was hardly any lymph node in this case. There were some retroperitoneal lymph nodes, but those were sub-centimetric. Maintained hilum was there, so those we reported as a reactive only. So in the PET, it was only cutaneous lesions which were positive for the PET scan, no other lesions. So for our point of view, paraneoplastic was almost out. Yeah, it's more of infection and inflammatory rather than any primary malignant pathology in the skin only, sir.
It's not possible to tell.
Sometimes there is a overlap, but by the characterization of the lesions, we can make. Yes, absolutely. Yeah, and there is another that we take many a time dual time point imaging, and there is a washout from the inflammatories and retention in the tumors or neoplastic. But there is not always some overlap is there.
Thank you so much, sir. Any more inputs? Yeah.
You, sir, I have not been seeing lymphomas or skin or patients for 25 plus years, but as a resident, I remember there was a case of a peripheral T cell lymphoma which had a lot of secondary extensive skin involvement. Patient had come for FNAC. So, have you seen peripheral T cell lymphomas in your PET scans? And especially these kind of ulcers and crusting big thick lesions in the skin, that's maybe that's a image that's in my brain. Have you seen much of lymph node involvement in such cases always, or can it come as mostly skin?
Some photos, madam, you have shown the black, but in some photo it is not like that. I think patient's dignity should be maintained. His identity should be disclosed.
So let's continue with unraveling of the mystery. Sorry, yeah.
The question again to Dr. Rakesh Kumar: how soon you can see the washout in the inflammatory lesions or in the infective lesions?
Usually, critically, it is 3 hours.
Okay, so
1
you
hour and 3 hours.
so you repeat the PETs again,
Only
CT?
spot images because of radiation issues. Target lesion, only that one that spot is repeated. See the washout.
Okay.
always overlap, as I mentioned.
Right. Thank you.
The patient also had some systemic features like significant fall in hemoglobin and respiratory distress. So, is it possible that other differentials like a small vessel vasculitis with associated pulmonary involvement, diffuse alveolar hemorrhage, could they have also been entertained?
Actually, small cutaneous, this vasculitis will not have this kind of presentation clinically. And as you can see, he had raised procalcitonin, raised TLC. So there could be, there was in fact, I think, underlying septicemia. In fact, blood culture also showed growth of E. coli. So that could be the reason behind that.
Any more comments or questions?
If we expect the kind of skin involvement in a cutaneous lymphoma case, we definitely expect some lymph node involvement. So, as he pointed out, and a rare, you showed only one this thing of blood sugar, one fine at the baseline only. Subsequently, what happened to the sugar? And rarely, it's a wild thought, but glucogonoma neuroendocrine tumor can present like this with explosive course, and patient may die of sepsis in those cases.
Yes, sir. Sir, the blood sugars, only one value was mentioned, but they began to get deranged because of the steroid treatment that the patient received. But they were in the range of 200 to 300. So not in the range where we would suspect a neuroendocrine tumor. Any other comments?
As an autoimmune manifestation of CLL, chronic lymphocytic leukemia, but the points against this are the absence of lymph nodes, no significant mucosal involvement also, and the TLC is also not that suggestive. So, but we have observed these types of lesions in as an autoimmune manifestation of CLL patients. This is very rare, sir. This is very rare, but we have seen a few patients of late recently also.
I think most of these presentations are very rare, but because this is a CPC case, so all of this is coming in. Let's see what Dr. Shipra has to reveal.
Yeah, thank you all. We received specimens at 3 points of time. So the first set of biopsies was received on 13th of August 2019. There were two biopsies, one from papule on the hand and the other one was vesicle over the left thigh. The differential diagnosis provided was paraneoplastic pemphigus and pemphigus vulgaris. Subsequently, we received two more biopsies after about 15 days on 28th of August and 29th of August. So this is the first set of biopsies. The one from the vesicle was within normal histological limits, but the one from the papule showed some epidermal and dermal infiltrate. There were these atypical cells which were distributed singly with marked discohesion. These cells were intermediate sized, had prominent nucleoli. They looked a bit rounded, and some cells had this brownish pigment which looked like melanin. At this point, it was difficult to differentiate which are the atypical cells and which are the keratinocytes. A similar infiltrate was noted in the dermis. The arrows over here point out the frequent mitotic activity. You can see that these cells have a vesicular chromatin with prominent nucleoli. Some of them have nuclei which are eccentrically placed. The differential diagnosis at this point of time did not match with the clinical history. Still, we went ahead with the immunohistochemistry. We first ruled out malignant melanoma and the tumor cells were negative for S100 and HMP45, ruling out a malignant melanoma. In addition, the atypical cells, we thought of hematolymphoid malignancy, and with the clinical differential of paraneoplastic pemphigus, we did a myeloperoxidase stain, which was again negative. However, these cells were diffusely positive for leukocyte common antigen. As it was not fitting in with the clinical diagnosis, we filed the case to get more clinical history as well as to get some details regarding any previous or recently diagnosed malignancy. Meanwhile, the patient had severe progression of disease. So these are the images on the left side which were shared with Professor Taru. And as she has described them, there were ulcerated and eroded plaques. There is much more extensive disease on day 17 of presentation with presence of ulcerated large plaques in the groin area. So these are the lower limbs. You can see a similar presentation, similar findings on the left side at the time of presentation. There are multiple confluent blisters on day 17 and again presence of eroded plaques. The face lesions also progressed over the 17 days. There were presence of nodular plaques at presentation with larger lesions on day 17. Before going ahead with the further immunohistochemistry results, I would like to show the H&E findings of the remaining biopsies. So this is the second biopsy which was received on day 15 of presentation. Again, a prominent epidermal and dermal infiltrate. Now these cells looked a bit different from the first biopsy. They look more like lymphocytes. And over here, we can see that these lymphocytes are different from the keratinocytes. They have hypochromatic and irregular nuclei with perinuclear halo, which has been classically called as a hole on a pillow appearance. The third biopsy was another, had different findings. What you see over here is a lot of serum exudation within the stratum corneum. There is minimal epidermotropism or infiltration of the epidermis. There is large amount of edema within the papillary dermis. There is a prominent infiltration of the dermal appendages by the same cells. You can see the infiltrate going down deep into the subcutis with very prominent infiltration of the hair follicles and the sebaceous glands, the eccrine ducts, and even perineural infiltration. The dermal infiltrate in the third biopsy showed prominent mitotic activity. Now the pleomorphism was much more. The cells were larger in size with much more prominent nucleoli and atypia. CD3, the T cell marker, the pan T cell marker was positive in these cells. CD7, another pan T cell marker, was positive. You can see over here the CD7 labeling the eccrine ducts and the hair follicles also. Two pan T cell markers, CD2 and CD5, were however negative. CD20, a B cell marker, was negative. Thus, we could reach to a conclusion that what we are dealing over here is a cutaneous T cell lymphoma showing prominent epidermotropism. But the clinical picture with which the case was sent to us was not that of any of the conventional common lymphomas we see. So this is the WHO EORTC classification. Sorry, sir. So we'll come to that. Yes, sir. So the WHO EORTC classification for cutaneous lymphomas delineates these various lymphomas, of which epidermotropism is seen in mycosis fungoides, adult T cell leukemia lymphoma, primary cutaneous gamma delta T cell lymphoma, primary cutaneous CD8 positive aggressive epidermotropic cytotoxic T cell lymphoma, which is right now a provisional diagnosis, and a small proportion of lymphomatoid papillosis. This is how we differentiate these various lymphomas by doing CD4 and CD8 IHC, as sir rightly asked. So our case was negative, dual negative for both CD4 and CD8. Thus ruling out adult T cell leukemia lymphoma, which is CD4 positive, and primary cutaneous CD8 positive aggressive epidermotropic cytotoxic T cell lymphoma, which is CD8 positive. We also did CD56 and cytotoxic T cell markers, including granzyme, perforin, and TIA1, all of which were negative, thus ruling out primary cutaneous gamma delta T cell lymphoma. We ruled out the possibility of lymphomatoid papillosis because this particular condition is associated with multiple remissions and relapses, which was lacking in our patient. Hence, we reached a final diagnosis of mycosis fungoides. But there was something different about this case, and we worked it up further. CD30 showed presence of more than 25% positive cells in the of the infiltrate, which confirmed a large cell transformation. We did an AB pass stain to look for mucin deposition within hair follicles, which is commonly seen when mitosis involves hair follicles, but it was absent. Direct immunofluorescence was sent to a private lab, and it had shown weak positive reaction in the interface zone for IgG, but was negative for IgM, IgA, and C3. A few days back, I talked to the reporting pathologist myself personally. I know her, and she said we call something weak or 1 plus positive when we have to hunt for IF at 40x, and 1 plus means when we have to actually hunt for it, it's not easily seen. I won't make any conclusion at this point of time. We'll come back to this later. We also performed PCR analysis for beta chain of T cell receptor, which showed a clonal proliferation. Hence, a final diagnosis was mycosis fungoides with large cell transformation, dual negative for CD4 and CD8. Before going on further, I'd like to congratulate Professor Taru for she had kept this as a differential diagnosis. Now, mycosis fungoides is the most common primary cutaneous lymphoma. Most of the patients present with early stage, that is stage 1A and 2A. Our patient was stage 2B, with the median overall survival of these patients being about 5 years. But our patient died within 2 months of presentation. So we try to decipher the causes behind it. There are 4 prognostic variables which independently determine the disease specific and the overall survival in mycosis patients. These include stage 4 disease, age more than 60 years, large cell transformation, and elevated serum LDH. Of these, 3 of the variables were present in our patient. Professor Taru has a train to catch, so she had told she'll be leaving early. The Cutaneous Lymphoma International Consortium study used these 4 variables to develop a prognostic index score. And our patient was categorized high risk. These patients have a 5-year survival of 28% regardless of the stage. Still, our patient performed worse than most of these patients too. Why? So, besides the 3 variants of MF, which have been recognized by WHO, that is a granulomatous slack skin disease, the folliculotropic MF, and pagetoid reticulosis, there are various other clinico-pathological variants of MF, of which our patient was of the bullous type. The first bullous mycosis fungoides case dates back to 1926, and in 2001, Baumann et al. They laid down the criteria for diagnosis of this particular variant. So these include clinically apparent vesiculobullous lesions with or without typical mycosis fungoides lesions, typical histopath features of mycosis fungoides with intra or subepidermal blisters, negative IF to rule out concomitant autoimmune bullous disorders, and negative evaluation for other possible causes of vesiculobullous lesions. Our patient did have 3 of the 4 criteria. Coming to the 4th criteria, we did see weak positive IF, but in the absence of C3 and lack of any diagnostic features of a vesiculobullous disorder on the biopsy, this was disregarded. On a review of literature, we found a recently reported case, a similar case, in which a 43-year-old male patient presented with 1-year history of illness with the clinical differential diagnosis of linear IgA bullous dermatosis. The lesion progressed to tumorous lesion within 4 months, and the patient died within 1 year of presentation. So interestingly, this biopsy from the tumorous lesion is similar to the 3rd biopsy which we received from the nodule on the face. On a review of literature, this particular variant of MF is rare, with less than 40 cases in literature, and clinically it mimics other bullous disorders, and the bullae may be either intra or subepidermal. There has been a male preponderance with mean age being about 62 years. The bullae may be flaccid or tense depending upon the localization of the split. The disease may be generalized or localized, and Nikolsky's kind may be negative or positive. So these are most of the cases till date have been subepidermal, as was our case too. There have been reports of bullae being both intra and subepidermal too. We also reviewed the clinical outcome of these patients. The outcome was not available in all the case reports, but wherever it was retrievable, of the 14 such cases, 7 died within a period ranging from 2 months to 2 years. So although WHO does not recognize this as an aggressive variant of MF, yet maybe we need to look more into it. The diagnosis of bullous MF is particularly also made difficult by some case reports having shown it to be associated with typical vesicular lesions, like bullous pemphigoid and pemphigus foliaceus. So what is the mechanism of blister formation in these patients? Well, there are some hypotheses. So intraepidermal bullae may be secondary to confluence of the clefts which are formed by the portreous microabscesses. The subepidermal may be because of loss of cohesion due to the epidermotropism, loss of cohesion between the keratinocytes and the basal lamina, or it may be lymphokine mediated. Whether et al. In 2011 had a case of subepidermal, a type of bullous MF, in which they did an ultrastructural study examination, and this revealed that the basal lamina was in fact intact and the connection between the keratinocytes was also normal. Thus, they proposed that the degenerated collagen bundles they saw in the dermis was probably either due to direct or indirect action of the atypical lymphocytes or the inflammatory cells present along with these lymphocytes. Most of the cases reported in the literature have been of the CD4 immunophenotype, with few being CD8. None of the cases was dual negative for CD4 and CD8, unlike our case. So coming to double negative MF. Double negative MF again is rare. Interestingly, this is also rarely reported with less than 40 cases in literature, as was the case with bullous MF2. Most cases have an unusual presentation. So 1/5 had classical presentation, rest all had a atypical presentation, with no case of bullous MF being reported till now in the literature. Clinically, most of these patients have a low stage disease, being 1A to 2A. Our patient was 2B. 6 had advanced stage at presentation. So the current case was unique in more than one way. It had an atypical clinical presentation. It was the bullous variant. It had a rapid clinical presentation with patients succumbing to disease within 2 months of diagnosis, of disease presentation, I should say. There were 3 aggressive prognostic variables which might have contributed to the rapid disease progression. And it was positive for CD7, which is usually lost in mycosis fungoides, and was dual negative for CD4 and 8. So mycosis fungoides is a great imitator of various disorders. We all need to remember this. And in such cases, the diagnosis is often challenging. Bullous MF is less recognized variant and can easily be missed or confused with other bullous disorders, leading to delayed diagnosis and management. However, presence or eventual development of typical lesions of MF and histopathology are helpful. Ultimately, it's a teamwork. We all win together if the patient goes back home healthy and happy. These are my references. And I'd like to acknowledge Dr. Kanika and Dr. Pankhudi for collecting the clinical details, Dr. Soumya for taking care of the P-cell analysis of the T-cell receptor, Dr. Anchal for organizing the CPC, Dr. Sanjay, Dr. Sujata, Mr. Pramod, and Mrs. Bimla for helping me in workup of the case. Thank you. So I'd like to invite Dr. Kanika for how they manage the patient and how can we correctly diagnose these patients in the.
First of all, I would like to really congratulate you for such an extensive evaluation of this patient. But unfortunately, our patient's clinical course was very aggressive. And within 15 days of admission, there was rapid progression of the cutaneous lesions, as well as significant decline in the general condition of the patient. And ultimately, despite IV antibiotics, the patient succumbed to sepsis on day 21 of the admission. And even until the time of the patient's death, we did not have a proper characterization on immunohistochemistry available from the pathology department, which is understandable because of the time that it takes to do the same, and also because of the very unusual immunohistochemistry findings in this case. So because of this, we were unable to initiate appropriate specific guided therapy because we were unaware of what were these malignant cells that were infiltrating the epidermis as well as the dermis. And so, and apart from that, this is a very unusual clinical picture. Bullous lesions in cutaneous T-cell lymphoma are very rarely described. And other than that, there were erythema multiforme-like lesions, and the Zank smear showed acantholytic cells. The DIF showed a weak positivity for IgG in the in between the keratinocytes. So all these findings were significantly keeping us away from the actual diagnosis. But in retrospect, when we look at the clinical pictures now, although it's hard to discern, the lesions on the face, even in the initial pictures, do show some evidence of infiltration underlying the erosions that are visible on the face. If Dr. Shipra could project those pictures again. So that to me is a learning point that, I mean, in an unusual presentation, we should be willing to, broaden our differential diagnosis and maybe do a more comprehensive literature search to see if such findings can be seen in other disorders. We did consider paraneoplastic phenomena, but we were unable to pinpoint that these ulcers and these erosions were actually infiltrates of the lymphoma. So this case has been presented because of its rarity, and also so that we are aware of such a presentation, so that we can take appropriate action in a timely manner for the patient. Thank you. Sir, it's hard to say. The patient had a cardiac arrest and he could not be revived. He did grow E. coli on his blood culture, so there was definite sepsis. There was hyponatremia, and although he never showed any abnormal cells on the peripheral smear, there were no lymph nodes palpable or even seen on the PET scan. So as per the staging, it seemed like a cutaneous limited lymphoma. But the course was unusually aggressive because of the large cell transformation and the other features on immunohistochemistry and the advanced age of the patient. So I think definitely both contributed, but the immediate cause was sepsis. Yes. Yeah. So we had been sending cultures from the pus as well as from the blood, which we usually do in such patients, because the skin being eroded becomes a site for entry of infection. But all of those came negative except for one blood culture which grew E. coli. But sometimes even in pemphigus lesions or paraneoplastic pemphigus, we can see a turbid fluid within the vesicles or the bullae. And it need not necessarily indicate infection of the bullae. So more commonly, it is actually just a collection of the inflammatory cells which make the fluid turbid.
Of course, it's a very interesting and challenging patient that we had. But while we were waiting for the diagnosis, we lost the patient. But in the literature, you said that some patients have survived for 2 years or longer. Yes, also. Is somebody from the medical oncology may like to make a comment about how would they be managing had we got the diagnosis on time?
So this patient has a very fulminant course, and the reasons attributed to this, maybe the which I attribute the most, will be the first, the performance status of the patient, the comorbidities, sepsis, and second is that large cell transformation that is of more importance as the pathology behind it, behind this aggressiveness. So this patient progressed while on steroids. So even if it was a stage 2B disease, more than 24.5% of the body surface area is involved, we'd like to take help of our radiation oncology colleagues for a total skin electron beam therapy. And perhaps I would also add some systemic therapy to it. targeting those large cells, CD30 positivity was there. Even if there is a bit of 30 positivity, we like to add brentuximab vedotin to this patient. So this is anti-CD30 monoclonal antibody. It's commercially available. It's now we are using it a lot for Hodgkin's lymphoma patients. It's available on compassionate ground also. So that would have been my choice because this has failed steroids. So total skin electron beam therapy plus the addition of brentuximab. Although for 3 and 4 stages we add systemic agents, but this agent we would add. I would like to add brentuximab vedotin. Other options would have been methotrexate. That is what is used mostly in steroid failures in mycosis fungoides. And after that, gemcitabine, etc. These are available. The other agents are vorinostat and then HDAC inhibitors. They are not much available and not in common practice. So I have not seen. In my limited experience, I have not seen those patients with PTCL presenting such. But as I mentioned, I have seen recently we had managed a patient of CLL with autoimmune pemphigus. It's a very similar picture, but the details of the findings were different. They were not nodules, patches like this, and there was severe mucosal involvement. So this was just a month or two ago during the COVID period. We had the dermatology colleagues also managing that patient. So PTCL I have not seen, sir.
Just can I make a few? Go ahead. You wanted
like a double negative cells, I would like to add a NK T cell lymphoma because recently one case from Dr. Ajay Gogia's clinic, it is a huge skin involvement and it's turned out to be a primary NK T cell lymphoma of the skin, and the case is a double negative. So I like to like a gamma delta, then the NKT, then thirdly I come to on more only basis of CD40, 4 and 8 without doing a clonality.
Transient purpurine was
negative.
Yeah. I just want to make
some double negative population.
Very general comments. One is that if somebody goes from onset of disease to death in 2 months, then mycosis fungoides really drops down on your list of possibilities. There are some who would say that you shouldn't call it mycosis fungoides. It might be a matter of semantics, but there was a time when people used to talk about aggressive mycosis fungoides, but that's been taken out now. So mycosis fungoides is an indolent disease. Second point I want to make is that if you use immunohistochemistry alone to exclude certain possibilities and to include others, then it's possible that we might err in giving a final label, because we know that there are times when neoplastic cells don't follow the rules. And I'll end with another very general point, because we have lots of people from different departments here, that the more the number of exceptions you need to make in order to accommodate a diagnosis, the less likely it is that that diagnosis is the right diagnosis. So if you have a bullous morphology, CD4, CD8, double negative, rapid course, then we are getting into a situation where we have to really ask ourselves, is this bullous mycosis fungoides, or is this something that we don't know about, for which the best name today may be bullous mycosis fungoides, but it's not a good name?
It's why, sir, TCR beta chain analysis was done, which was positive. So beta chain means the cells involved are T cells of that particular T cell.
But it doesn't tell you it's mycosis fungoides.
Yeah. I agree. But right now we don't have any other name.
Alpha beta type. So you see the rule out your NK cell, gamma delta, all those rule out. So that will be helpful. That's why you get the beta.
Another thought that I had when I looked at the histopathology, the first histopathology image that showed significant epidermotropism and with such an aggressive course was the primary CD8 positive aggressive T cell lymphoma. Now, there is a clue on H&E also to differentiate it from the regular non-aggressive MF, which is that you get a lot of necrotic keratinocytes and significant amount of spongiosis, which was not there. Yet, because of the bullous lesions, the ulceronecrotic lesions, a very aggressive course within 2 months, CD8 positive was really on my mind, and that's why I interrupted to say whether CD4 and 8 was done, because we've seen a couple of patients, extremely rare entity, but we've seen that admitted in our of this entity, where the patients die very, very quickly. But to see both CD4 negative and CD8, CD4 and CD8 negative, and that too epidermotropic and becoming so aggressive, it's really, really rare.
Second day or third day, I will give the diagnosis as a cutaneous T-cell lymphoma. Will you treat? Diagnosis after this.
No, clonality was done now for CPC.
Killing steroids, electron beam therapy can be given. The electron beam therapy doesn't like
Dr. Kanika. Yeah, definitely. Just a couple
Actually, the first, sorry.
couple of clinical points. Whenever we see targetoid lesions, either it suggests something going on atypical, whether it is in SLE, a condition where we don't see, like in this patient, or some other condition, something which is aggressive, going fast, and we have to look for more things. Just one thing, does LDH help in retrospect, thinking of something which is malignant rather than just autoimmune bullous disease?
Yes, sir. So LDH was elevated, and since one of our considerations was paraneoplastic pemphigus, we assumed that whatever primary malignancy is there is causing the raised LDH. So we could not attribute that the skin lesions per se were infiltrated with the lymphoma cells. I can take Dr. Raja's opinion.
We must compliment Cipra for having put in so much of efforts to raise the diagnosis. But since you reviewed the literature, the people who survived for longer duration, what therapy did they receive?
That's also mentioned. Yeah, it has been variable. So topical corticosteroids, then topical nitrogen mustard. This patient was given methotrexate. Yes, sir. So yes, correct, sir.
Talking about, no, I was a senior resident then. I had gone for an FNAC in IRCH ward. There was an inguinal lymph node, but the rest of the patient looked exactly like this. So I did an FNAC from that inguinal lymph node, came back. We looked at it and there were malignant cells, blasts. So we called it a high grade lymphoma. We didn't have, CD3 and 20 in those days. That patient was in the ward. Me and Dr. Kapila went and saw the patient again, because we wanted to prove what it was or to do biopsy, and that patient also died. So we were in touch with the doctors who were treating, and that patient also died of a very aggressive course. The lesions became more infiltrative, more thick, so much so that we attempted an FNAC from the dermal portion of the thickening. But that didn't look very different. And that patient died less than a month with very similar looking lesion.
Yes. Presentation.
And to answer the treatment modalities that have been used for large cell transformation, usually because CD30 cells are positive, so brentuximab, as Dr. Raja said, is a commonly used modality. And generally, even if it is a skin limited disease with large cell transformation, because of the aggressive course, systemic agents are recommended for the treatment. So it could either be methotrexate, oral corticosteroids, brentuximab, gemcitabine. So these are all modalities that have been used in patients with large cell transformation. Yes.
Thank you.